Hi, welcome to the Elle Russ Show, where I deliver content intended to inspire, educate, and motivate. Engage with me online at elleruss.com and on social media. Enjoy the show. Hey everyone, just a quick 1-minute announcement to let you know about my virtual courses and free masterclasses. I have courses and free masterclasses based on both of my books. I have the Ultimate Thyroid Course. This is your answer to solving any thyroid issue, whether it be Hashimoto's, radioactive iodine, thyroidectomy after thyroid cancer, or just general hypothyroidism. Reverse T3 issues as well. It's an incredible value at 17 modules and 29 hours of content with amazing guest expert tutorials. I also offer the Ultimate Confidence Course. That is 15 modules and 14 hours with also a few guest expert tutorials. An incredible value, and I have free masterclasses on both of those topics as well. Visit elleruss.com to learn more. Hi, Amie. So good to speak with you again. How are you?
I love talking to you, Elle. I'm great. Thank you.
Yeah, so I am just, thank God for Amie, because she is also one of the other, one of the patients out there that's outspoken at least about, and thyroid experts that's outspoken about the fact that she is on T3 only. And so am I, except for I take a skosh. I take now, at least for the past year, I take 12.5 micrograms of T4 in the morning, but I take T3 the rest of the day. This is such a problem. We've talked about this before, and we want to get into it because doctors are so scared and so worried and uninformed about T3. But let's just start off with your thyroid story. Tell us when you started to notice shit was hitting the fan, and then what was your first order of business, and how did you graduate to eventually realizing that T3 only was the only thing that, helped you recover?
Yeah, absolutely. So, like so many of us in this space, just like you, pain to purpose story, you go through your own health shit in the beginning, and then you figure it out from there. We're rewinding about 25-ish years ago. And I was competing. I was doing figure shows. So for those of you who don't know, there's bodybuilding, you're really big, you're kind of like manly looking. And then there's figure. Back in that day, it was still very, very feminine looking. You just needed to be lean and muscular. And, you step on stage in a bikini and get judged. So you're really in this diet phase leading up to a show. You're dieting hard. You're eating chicken, fish, and broccoli. You're hitting the gym twice a day. And I was doing all of that, and I had done it before. This wasn't my first show by any means. I did it multiple times before, but this one particular show, I was getting ready for the NPC Pittsburgh, which is a bigger show, and the scale was going up instead of down. Now, biologically, we can talk calories in, calories out all day, whether it's true, not true, whatever, but it just shouldn't have been happening. With the effort that I was putting in, the scale should not have been going up whatsoever. So I bagged that show because there was no way I was going to be ready for it. And I started going to doctors. And I always joke, I started with my sister. So I blame her for the first misdiagnosis.
Is she a doctor?
Oh, yeah. Yeah. She's a geriatric doctor. But, you always go to family first. You're like, help. So I don't even know. I wish I could go back. I wish I could go back and see the tests that they actually ran on me, because you and I know it's not thorough. That they tested TSH and maybe T4. That was it. Maybe. So
I bet your T3, I bet your TSH was low, and along with the other ones, because if it was an over-exercising calorie restriction thing, that would be like the euthyroid 6 syndrome of like starvation-y type of lab looking, you know? So it was probably like mine, which, because I wasn't bodybuilding, but I had that same over-exercising chronic cardio shitty. Yeah.
Right. And I'm sure that didn't help the situation, but you're right. Like you said, they kept telling me, you're normal, you're fine. You're normal, you're fine. Everything looks good. 6 doctors later, and I heard the gamut. I heard it's in your head. I heard you're just getting older at the age of what I was like 22. I heard eat less and exercise more, which pissed me off because I brought in my diet. I brought it in on paper. So they couldn't tell me that, I must be overeating. That's why I'm gaining weight. And 6 misdiagnoses, finally got the diagnosis of hypothyroidism. And I left the office. I was like, woohoo, I got a pill, right? They gave me Synthroid. Got a pill for this. Now I'm going to lose some weight. 5 months later, nothing, not a pound. I didn't feel better. Not a single hair grown on my head, nothing. And so I started doing research. And back then, I always joke, I have my big gateway computer, right? And we didn't have our computers in our hands. I had to look up stuff. And I found all this information on T3, and I brought it back to my doctor and I said, hey, there's this thing called T3. Turns out it's active. How about that? So how about we use that with the T4? Because, you know, some prescribers are doing this. She goes, no, I don't do that. I said, well, I'm going to find somebody who does then. And I kept hearing the name of a functional. Well, back then it was integrative, functional doc, functional. And I'm like, okay, you know, you hear the name 3 times, you eventually go. So I go to him. And by this time, I mean, I was just like we all are when we don't have an answer, depressed, anxious. Just, I had no motivation to go out. I didn't want to get dressed. I was trying to squeeze myself into clothes that were all too tight. So, you know, I was going downhill mentally, and it was only 5 months, but without change, you know, it really starts screwing with your head. So I go to this guy, you know, my last hope, and he does all the right testing. He talks about diet. He talks about supplements. He talks about T3. So I go on NDT. I go on Armour, and that helped tremendously back then, helped tremendously. But then after a couple of years, it just stopped working. So we switched to T3 and T4. And this is where, when I even talk about figuring out if you're T3 only, there's a lot of trial and error in that, because I know we were testing my reverse T3, but for me, I will have symptoms before the reverse goes up. So you and I talk about experimenting on ourselves all the time. If you give me 25 micrograms of T4, like you're taking 12.5, if you give me 25, and I've tried this before already, I will go hypo in a week. Now that's long before the reverse T3 will climb. So it was more of a trial and error that we figured out that I am T3 only. It wasn't so much the elevated reverse T3. It was just more how my body responded when given T4. So then that's kind of the transition probably.
Okay. So you didn't have, did you ever have a high reverse T3, or were you just like, hey, I don't, but T4 is not working? Cause that happens too.
Yeah. Yeah. It was more T4 is not working. My reverse stayed pretty low. And again, if I could go back and look at my labs, oh my gosh, that'd be amazing. You know, who knew I would get into this arena? And so that's a point to always save your labs, always have a file or do a spreadsheet. But yeah, I don't remember us ever talking about reverse T3 being high. I just remember how I felt. And it was like clockwork. You add it in, I'm 5 pounds heavier by the end of the week and depressed. You take it back out, I spring back to life.
Yeah. And I wonder, I mean, you know, speaking of like probably one of the, you know, fellow author, Paul Robinson, who like discovered after 30 years, it was really about the fact that he finally took the D1, D2 genetic test. I don't know, it was like $600 or something. And he found out that, well, no wonder he could just never convert. It had even nothing to do with reverse T3. It just T4 wasn't right. Do you know what I mean? It sounds very similar to you, which is a damn shame. And so that happens to a lot of people. It happened to me as well. You go on NDT and you're like, hey, that's great. And then a couple of years later, you're like, oh shit. You know?
Yep.
All right. So when you started to do T3, so eventually were you like, all right, I'm getting off the NDT. Did you add T3 to the NDT first? Like, how did you figure out?
We just did the total switch. This was back in, gosh, what year was it? I want to say like 05-ish, 06-ish, where Armour was starting to have some issues. So yes. I first thought it was that. I thought, you know, maybe it's not me responding to the medication. Maybe it's the medication that's a little bit messed up and they're having issues and whatever. So we just did that switch from Armour to Synthroid and liothyronine because of that whole time of Armour. And then I was on the T4 and T3 together, and I can't remember how long. I mean, I would say maybe a few months. And then that just wasn't working. With every increase in T3, it didn't make me feel better, which I know a lot of your listeners are probably like, oh yeah, that's me too. We keep going up and I'm not feeling any better. It might be that T4 component. So luckily I was working with a very knowledgeable practitioner at the time because he was integrative, functional. And he was just like, you know what, let's just pull the T4 and see what happens. And I got better. So there was my answer. I didn't need labs. It all comes down to what I always say, ask your patient, how do you feel? Because how you feel is a much better marker than your labs. Now, I mean, okay, could it be other things? Like if you're like, well, I feel like crap, it must be my thyroid. Yes, maybe, and maybe not. It could be hormones. It could be,
maybe you just have low iron or something. I mean, it could be a bunch of different things that sometimes are simple fixes too.
Right. Right. So I'm not saying that so everybody runs out and asks their doctor for more thyroid medication or change the thyroid medication. But I knew my body, and I knew those little tiny tweaks that we would make when we put the T4 in, and I knew how I was responding.
Let me interject here and talk about something we chatted about a little bit before the call, which was this also goes the other way. People are told to go on thyroid hormone replacement when they should not be at all. And again, this is what you're talking about. Ask them, do you have any symptoms? I mean, you can't just look at a lab and go, oh shit, you need thyroid hormone replacement. And the person's like, I feel fucking great. Everything's great. Metabolic, like, you know what I mean? This happens a lot. Actually, it happened to Mark Sisson and Brad Kearns. A doctor just tested their TSH. They had woken up, fasted, go to the gym, then they go in to get their blood work. So their TSH on a range of, let's make it easy for the audience, 0 to 5. They maybe had a 3.5. And the doctor was like, oh my God, yeah, I'm worried about your thyroid. You need Synthroid. And they're like, I feel fucking great. And then I look at their labs and they never even tested the free T3, of course. And again, so people are unnecessarily put on it when they don't need it. And then also the opposite as well. They're not asking like, well, how are you feeling? What are your symptoms? And they're not looking at diagnostics either. They're not looking at temps and other things. These doctors just aren't even considering any of it.
No, they're not. They just don't have the time. They don't have the time to really sit and dig into your health as a person, who you are, what you do, how you feel, how you eat, how you sleep, do you poop? They don't have the time. So that's where they're dropping the ball. And I do see that as well. I'll have patients come to me, and it's very rare because, as we know, usually it goes the other way, that they're misdiagnosed and they're feeling like crap and nobody has helped them, and nobody has even looked at the fact that maybe they are walking around with a legit TSH of a 4, but it's still within normal limits, and they're feeling like ass. But in the case of Brad, I mean, here's, you got a guy who's fit, takes care of himself, feels great. You have to ask that question. And yes, I have seen patients on thyroid medication. And usually what happens is they'll be given a little itty bitty amount that then makes them hypo, because now you've given them just a tiny amount and you shut down the feedback loop. So
yes. Yeah. Well, and that's one of the things, I know you know this too, but we'll just push it into the audience. This is the biggest mistake patients and doctors make. They will give a patient an entry-level dose of thyroid hormone and be like, great, see you in 6 months. No, see you in fucking 3 weeks. That is enough time to see what that T4 is doing. And you need to climb up the ladder in a steady fashion to get your optimal dose. Otherwise, like you said, it'll start to, you introduce the exogenous hormones, it starts to shut down the feedback loop. And then they're like, and you know what, it kind of happened to me. So when I had started NDT, I initially in the first 3 weeks was like, oh my God, this is my answer. And then I got hypo symptoms that I hadn't even had before. And I remember being like, what's happening? And then I realized, oh, I need more. I need to move up quicker. Do you know what I mean? I was waiting too long. I was on that initial first dose for too long. And so And doctors don't like that. They're like, see you in 6 weeks. No, that's really too long. 6 weeks. And then it's another week for the test to come back. Now we're at 7. You should have been upping at like week 4 or whatever after the labs came back. So that's an important point, and I'm really glad you brought it up. Let's, so your dose, are you still on 75 micrograms of T3 twice a day?
Yes. Yep.
Okay.
I've been on that dose for a while.
Okay. So sometimes I've known, and I had to do a lot of tinkering over time, and I don't know if you ever had this at one point, if you were on more and needed less. That has happened to me over time, where I was once on 100 micrograms and I needed much less over time. But let's consider, I had heavy metals. I cleaned that out. I went paleo. I optimized some shit. You know what I mean? And then as I got more metabolically efficient and calorically efficient, my T3 needs were a little less. And sometimes for people, that's not the case. CJ Hunt has to take 150 micrograms a day too. And again, that's what's right for him. So your dose would probably kill me right today. But, and that's the other thing too. There is no amount of that's too much or that's high. Like there are people that have to take 4 grains of NDT a day that would absolutely be wrong for someone else. And I want to just throw this out. So let's talk about, another scenario. And this actually works with like the Brad and Mark scenario. When you get these guys like Ben Greenfield, Mark Sisson, Brad Kern, these like metabolically beast efficient dudes, they often have a lower free T3 than even normal people. Like let's say the middle of the range is 3.0, or 3.1. They might have a free T3 of 2.9, but that's okay. Like that's not an alarm for them. They're just more T3 efficient, I've noticed. I even know someone who has their thyroid removed. They're on Armour. TSH suppressed, free T3, like, no, maybe it's 1.2. And the TSH was 2.9, maybe middle of the range was 3.1. And I said to them, I said, hey, you do have room to grow here if you needed to. How are you feeling? They're like, I feel fantastic. But this guy was like an ultra paleo fit, badass dude. And that made sense to me. Do you know what I'm saying?
Yep. 100%.
And so that's the other thing too. Anyone who's trying to target a number, it's like, what's the right number for you? There are people now, normally, right? I mean, people on NDT, they don't really feel good and optimized until they're kind of above the mid range on free T3, but that's not always the case.
It's not always the case. No, it's not. Yeah. We can give optimal ranges in functional medicine. We can say, because the functional ranges are much different from the standard lab value ranges. I mean, many of our listeners know that standard lab value ranges are taken from a sick population. Functional comes in and says, give me your Mark Sissons, give me your Ben Greenfields, give me your badass people. We're going to test them. And that's where we're going to find that optimal range. So that's where people most of the time feel their best. But still, I mean, even in functional medicine, it's still a range. It's not in the books and 100% for you. You still have to come in with how you feel. And that's really why, I mean, thyroid medication and just thyroid treatment is so nuanced. It's so, I mean, that's why doctors really need to bone up. I did a whole half education, half bitching episode on my podcast last week or 2 weeks ago, just for practitioners, just for prescribers to listen to, because they really need to get detailed and bring in personalized medicine when you're dealing with thyroid. Otherwise, you're going to drop the ball. And like I say on that episode, it's going to come back to you, the prescriber, you, the practitioner, you, the doctor. You're the one making the decisions for these people. And if you're underdosing them, if you're not listening to them, it's coming back on your reputation. And they're going to go somewhere else and go, that person didn't help me. So if you want a bad rap, go ahead and keep messing up people's thyroid and not listening to them. But it's such a nuanced art in getting someone optimized.
And I think it's really, I mean, look, I mean, I'm not, it's kind of why people like us who've been through it, we know how it feels. We understand the nuances. You know, it's pretty difficult unless someone's been practicing it correctly for a while, that they're going to get to see all this stuff, like maybe a Dr. Forsman or some other people who really get it and they understand, and they're not afraid of, you know, prescribing T3, and they're not afraid of patients experimenting and practicing medicine with them. How did you always start off with a 2-dose thing on T3? Did you like, what was the trajectory that ended you up on 75 twice a day? Like, how, you know what I mean? Like, how long did it take to tinker there? Did you do more than 2 doses at one point? Because, you know, listen, a lot of people who do T3 only have to do 3 to 5 doses. It just depends. I kind of do 3 doses. How did you get to 2? Can you tell, were you always at 2 doses?
You know, luckily, again, coming back to my mentor, luckily he was brilliant enough to tell me to split dose the Armor. So Armor has T3 in it. We always want to kind of split or multi-dose T3 because it's in and out of your system, right? So he told me that from the day I went on Armor, I was split dosing. And it really does become second nature. Like, it just becomes like, okay, time for, you know, a little alarm goes off in your head. So then when I moved to T3, T4, I was still split dosing that T3. And that twice a day dosing seems to work for me. Now, ironically, I did a Dutch test. I went over this with Karen Martel, and she was like, you might want to dose it 3 times a day because you're getting this huge cortisol spike in the morning after your first dose. So I could break it up more, but I don't feel that. I just did the Dutch for shits and giggles. It's not because I'm feeling a certain way. So like, if I started to feel wonky, sure, I would I would go 3-4 doses. That's fine. But this split dosing just works for me. Yeah.
Tell us, do you know what are your labs like? Because here's the thing, so when you're on T3 only, the labs don't always, you can't always completely count on them. Meaning, like, let's say, what's your last dose is what, before 5 p.m.?
Yeah. So I take my second dose, usually like 1 or 2, so it doesn't mess up my sleep.
Right. And by the way, that is something like, it's just individual too. Some people are afraid that T3, because they think it's an energy hormone, is going to keep them up. But sometimes, like, I take a dose right before bed. So, you know, that's individual too. And that's something people have to figure out for themselves. I know Paul Robinson as well cannot take a dose past 5 p.m. or it messes with his sleep. I just want to say though, that it is not necessarily equation, like, because people go, oh, T3 is energy, it's going to keep me up, I'm scared. And you're like, well, until you try it though, don't make that determination, because that is individual too, right? Like some people just have issues or not. What do your labs look like on that dose? I mean, obviously your TSH is going to be fucking nothing. Your T4 is going to be nothing. What does your free T3 look like?
So this is interesting too. And coming up here, when I want to time it on day 3 of my cycle, because I'm checking some hormones, but I am going to do a T3 test, not run through my insurance. So this is not documented anywhere. I'm going to do what you and I talked about before last time we talked about, actually testing myself after I take my dose. So I'm going to take my morning dose and then go to the lab like an hour or 2 later, just for, again, shits and giggles, my own kind of
I would do it.
data point.
I would do it 2 hours after. And that is really interesting because, okay, so did you do the test yet?
Not yet. It's coming up, but I can talk about my old testing if I wait 24 hours, but yeah.
Yeah. What's your normal fasting in the morning T3, free T3 test?
So it's actually kind of comical. And again, here comes the nuance, right? So the last test I did, I think I left 36 hours, which normally I tell my patients 18 to 24 hours of no T3 med and then go to labs. I waited a little bit longer and my free T3 was a 1.9. So, right.
Which seems really, which by the way, that's very low, right? Because the range is like 2 to 4. Okay.
Yeah, it's very low. And just like you said, my TSH is 0.007. My free T4 is non-existent. My reverse T3 is less than 5. We know that. That's T3 only. That's just how it rolls. That's what it's going to look like. So what's interesting when I go longer without, it doesn't, now that 1.9 does not mean that I need more medication. I do not want more medication. I'm fine. I'm good. But what it's telling me is that years and years of thyroid hormone replacement, along with Hashimoto's, has slowly destroyed my own thyroid production. Now, do I care? No, I don't. I'm good. I'm fine. I'm good. I don't care. It's not a bad thing. It's just interesting. It's just data. So I just went, oh, yep. Well, okay. Well, that just tells me that, yeah, I mean, T3 is running my body. Thank God. Right.
Yeah. And after all this time, you may have more reserve of it somewhere. Do you know what I mean? Like, again, it could be lasting a little bit longer than when people initially started. Yeah. So that's interesting. And so if a dummy doctor were to look at that, they might go, oh, you need more T3, or someone would think that. And that's why these labs, again, because if your last dose was at 1, you go the whole day, you wake up in the morning. All right. Yeah. Stuff has dissipated. So when I did the test, so what I did is I woke up in the morning fasting, took the blood test. Then 2.5 hours after my second dose of T3, I also took the blood test. My free T3 was like a 7 at the time it was peaking. Okay. Yep. And the range is like 2 to 4, just for the audience. Obviously, you know that. And, I was like talking to my doctor and I was like, okay, is this bad? He goes, no, I'm not even worried about that, because that's when it was peaking. It's fine. You know what I mean? I mean, where another doctor would go, you're going to fucking die. You're going to have a heart attack. Right. Again, it's just information. The more important thing was like, well, how do I feel? You know what I mean? How does it feel? Do I need to reduce or increase? You look at temps, right? All of these things are they're so important. All right. So what else? Okay. Let's talk a little bit about some of the dumb things we hear.
Yes.
So that people listening can relate. First of all, you've already mentioned a couple. You just need to work out more and eat less because you're getting old. So the weight gain thing, they can F off. The other thing I've heard is someone on thyroid hormone replacement, but they're still not on enough. So they're still depressed. And then the doctor is like, this is the dumbest thing I've ever heard. They're like, oh, well, depression is a symptom of hypothyroidism. So yeah, you're going to have that. And I just want to like stop. And I mean, if you are on the right thyroid hormone replacement, the elimination of all symptoms, no doctor should go, right? So that's a doctor that just doesn't know how to treat the person, and they're chalking it up to a list they Googled of symptoms for hypothyroid, but you shouldn't have any symptoms. Can you touch on this?
Yeah, I hear everything. And honestly, I'm still surprised. I'm still, my jaw will still drop to the floor at times when I hear stories from patients in the conventional medicine world and what they hear. So yeah, I will hear just medical gaslighting out the wazoo. People think that they're crazy. It's all in their head. Well, yeah, I just must be getting older. One female doctor told another female that you're just going to have to learn to live with all of these symptoms because you're a woman and you're just getting older. And it's like, well, okay, obviously that doctor's not going to live a very fantastic life as she ages because she's thrown in the child at the age of 45. I mean, it's just the things I hear. So a lot of fear around T3, just miseducation out the wazoo, fears around T3. Yeah, it's going to give you a heart attack. It's going to cause bone loss. Still fears around suppressed TSH, even in the functional community, which is why I always say you have to find a thyroid expert, not just a functional doctor.
Yes. I have sat on panels next to doctors who said something wrong about thyroid right in front of my face. And I'm like, oh my God. You know what I mean? Yes, that is such a good important. And again, talking to patients like us who understand, Amie is an incredible resource for this, particularly because she knows this side that doctors are adverse to, which is T3. I mean, unless you get a awesome doctor like mine or a few others out there that kind of know what's up and they're not practicing medicine for the fear of getting sued.
Yep, exactly. It's all around fear. It's 100% around fear. Even I know a doctor, I won't say any names. I know a doctor that is, claims to be functional, but is scared of giving T3 to a pregnant woman based on the AOGC, whatever governing board's recommendations for thyroid in pregnant people, because of fear of losing her license. And it's like, okay, so now the doctors that even know better can't practice good medicine because we have these holier than thou organizations saying, well, you're going to lose your license and you're not going to make any money if you do this. So what are they supposed to do? I mean, it's insanity. Yeah,
that is a very out of integrity, unethical place to be. They'll get theirs for that. They'll get theirs. Yeah. That's going to come back to bite them. Here's the other thing that I've had the experience with in talking with people. And like, it doesn't matter where you are in the world. This is the same story. I talked to someone in Croatia the other day. It doesn't matter where you are. The same fuckery. In Croatia, they don't even test reverse T3. There's nowhere in the country you can even get it. So, that's always a problem. But here's another thing. I want to see if you've had the experience either yourself or with people. So let's say someone's on T3 only, and then they're like, oh, I'm getting tired. And then they just think that they need to take more T3, but then they're making themselves hypermetabolic and actually hyper. And then they get tired, but they think because T3 is an energy hormone that they should, do you get what I'm saying here?
Yep.
And go, and they didn't do any of the right stuff. They weren't taking diet, they weren't looking at it correctly. And they just in their head were like, oh, I guess I need more. Oh, and I'm tired again. I guess I need more. And that's also, people don't understand that too much T3, because I've been on too much T3 before. It's exhausting. Hyperthyroidism at first, you get a little bit of an extra jolt to focus and whatever. And then it kind of falls apart and backfires because of what it does to cortisol and glucose. Can you chat a little bit about this? Have you seen this too?
Yeah, for sure. And it's funny that you're bringing this up because I often think that, with what you and I do and the message that we give, and really wanting to educate our listeners and also educate their doctors and make the listeners be a better patient advocate surrounding T3 and how many people we see that aren't on T3 and are told that T4 only works. You and I talk about it so much that we do create monsters, and we create T3 monsters. And I see this in my patient population too, where I really have to reel them back in and say, listen, it's not more T3 as the answer all the time. Sometimes it is. But yes, if you self-medicate or if you go up too high, or even if you're working with someone that is T3 open-minded and increases your dose and you feel awful and I just had ironically, I had an email this morning with a patient that we just increased her T3 dose about 2 weeks ago. She's like, you know what? At first I felt great, but now I'm feeling just horrible. I'm feeling, and it's because she's going hyper. And it's like, okay, back down. Let's back down. It's right. More T3 is not always the answer. So it starts to, when you get tired, and this applies to if you're taking Adderall for ADD, if you're taking hydroxycut, God, is that still on the market? I don't even know. If you're taking any kind of stimulant and you get tired, you are taxing your adrenals. Yep. You are burning them the hell out. So that's not a good thing. Like you said, Elle, it's not necessarily a good thing. More T3, more T3, more T3. No, you want to find that dose, that sweet spot that is right for you. And if you're still dealing with fatigue after that, well, number one, if you're a woman, that's part of the whole equation. Progress is not linear. You're not going to have good days every single day. Just because you have a bad, tired day doesn't necessarily mean it's your thyroid and that you need more T3.
Yes.
We have to look at hormones. We have to look at insulin. We have to look at inflammation. Are you getting enough vitamin D? Are you eating enough protein? Are you even sleeping? Are you drinking alcohol that's fucked up your sleep? Are you pooping every day? I mean, there's so many other factors that come into fatigue. Don't just up your T3 thinking that's the miracle answer.
Well, yeah. And that's the thing, because when I was first doing this and there were like no information really out there about T3 at the time, every time I would like Google cytomel or T3 or liothyronine sodium, like 50 bodybuilding websites would come up. And I would be like, and at the time I was like, what the, like, why? And so I started to look on the threads and I'm going through like these bodybuilding websites. And then I realized that these motherfuckers just like before a competition to lose fat, they, jam themselves with T3, but then they have to offset it because of the catabolic nature of T3, which I want to talk about in a minute.
Yep.
And they screw themselves up. Obviously, it's not a good plan, but it just goes to show you what an important fat burner it is, but also the problems. Because when I was on too much T3, I couldn't build muscle. It seemed like there was no lean muscle mass. That's also an issue. You become like catabolic.
Mm-hmm. Yeah. And you had mentioned earlier, I'll circle back real quick to a question that I didn't fully answer. In terms of, do I ever change my dose from the 150? You and I talked about this the last time we talked. There's an intuition that goes into that too.
Yes.
And you build that intuition over time. So don't start off on thyroid medication and in year one, you're tweaking your own dose kind of thing. I mean, you could, but it really takes like just really tapping into your body and listening to your body. There are times where I will not take 150 because I just know, yes. I'm going hyper. I just know it. Rarely do I go over 150. I would say during times of like illness, surgery. I mean, those times I might need a little bit more just for a couple days. And then I go back down to my normal dose and then I might drop down and come back up. Okay.
I like that you're saying this because this is also the reason for, hey, if you can get optimized on T4, T3 combo, it's the fucking easiest. Okay. Everyone would love to do that. I would love to be optimized on that. It's easier. And it's weird when I do tell people what you just expressed, which is like, there's an intuitive thing when you're on it so long that you just know there are times when I do skip one of my doses. It's like, yep. and it's almost like we can't quantify it. It's something you have to experience, but people who are optimized on T4, T3 rarely have to do that because the whole feedback loop other than the TSH is really working for them in their favor. And it's great. It is smoother. It is easier. I wish you and I could both be that, but we're not. So we have to resort to the last choice. And that is really why it is the last resort. I mean, again, it could be the first resort if someone has, a problem with T4, but at the end of the day, it does involve tinkering. It's a little bit harder and you have to know a lot as the patient because you can't just get your blood tested and have that work every time. You can't call your doctor every week. That's why you need to have a relationship with someone who can allow you to tinker and that you are knowledgeable enough. You have to be extra knowledgeable when you're on T3 only. Am I right?
Yes. 100%. Yes, definitely. And that's why, so if that email that came in this morning of, hey, I feel worse, if that person had been optimized, let's say for 2-3 years, she wouldn't even have to email me. She would just drop down on her dose and just know like, oh, wait a minute, this is too much for me. I'm backing off. But that's why we're here educating. And so that you as a thyroid patient can get to that place of being optimized and being intuitive and listening to your body at the same time. Yeah.
And I always say, look, I go over the years when I've had an issue where I'm like, ooh, my hands and feet are hot. Like my ears are hot. Something's wrong. Mm-hmm. Like I go to temps right away. I go to the basal in the afternoon and I go, okay, hold on. I'm starting to experience this. Like I need to drop, you know what I mean? Yep. I can do that on my own. Right. Because I knew enough and I have the diagnostic tools like pulse and everything to go, okay, hold on a minute. And that's also the beauty of direct T3. Let's talk about that for a minute. Because you take direct T3, correct?
Yep. Exactly.
Yeah. So I don't, it's not that slow release T3, right, is like, for the people that don't know, you would take a pill in the morning and it's supposed to spread out an even dose of T3 over like 8 hours. So sometimes you would take it twice a day if you were on slow release T3. But damn it, it's really not optimal. And can we talk about that? Because you got to feel it out and you need to be able to adjust. You can't do that when you're on slow release and then you don't know where in the day. Can you kind of give us a little bit of your thoughts on this conundrum?
Yes, this is 100% anecdotal evidence.
Yes.
But in how long have I been doing this now? 26 years or something. I can honestly say I have never, ever once seen a person optimized on slow release T3. They're usually still hypo. Their doctor swears up and down that slow release is the way to go, unless it's someone who is hypersensitive to T3 and they are out there. Those are the ones you give them 2.5 and they're crawling out of their skin and they're anxious and they're jittery and they're like, I can't handle it. And I'm like, but your T3 is a 1.9 and you're hypo, like you're gaining weight and you're tired. So those people, we will use slow release because they tolerate it so much better. But if you think about what is slow release, they're putting something in that is preventing absorption. So then the question becomes, if you're given, we'll just use a number, 25 mics of slow release T3, are you getting 25? So now when we look at your labs, I don't know how to even adjust your dose because you might be getting 15 micrograms of that 25 actually absorbed by your body through the day. You might be getting 10. I don't know. We don't know. There's no data on it to say, well, if we give you slow release and we put this cornstarch in it to slow down the absorption rate, so it does slow release over time, and we put it in a capsule that breaks down really slowly, how much are you actually absorbing? I mean, you got to eat at some point during the day, right? What if that T3 is releasing during the time that you're eating and now you get the food in your stomach and now that's slowing it down? You take 10 other supplements that are gel-based caps and that's slowing it down. You don't know. Yeah. You just don't know. And you can't, like you said, you can't adjust your own dose. You don't know where to go.
Right. It's really kind of walking in blind. I would also say that, and this goes to like, you're on an even dose, right? 75 and 75. But then there's a lot of people that take the same dose 4 times. Like I take 10 micrograms 4 times a day, 6 hours apart. But sometimes a tailored dose strategy, which is what I do, works for me. Yes, I take more in the morning and less in the afternoon. I mean, and again, this is something you feel out. I initially took 25 micrograms like 4 or 5 times a day at one point when I needed that. At the very beginning, I was a disaster. Then I started to go down, adjust doses. And, again, I need less in the afternoon than other people. So an even dose strategy can be great. And it's usually where someone should start, kind of to figure it out. But then you might need to go to a tailored dose. And then in that case, the slow release T3 is just absolute garbage.
Yep. 100%. Exactly. I just don't like it. I know there's going to be 1 or 2 listeners out there that are like, but I'm amazing. And I feel great on slow release T3, but I just don't like it.
Yeah. We've heard so many, okay, so one of the other things too is that sometimes people think like, okay, let's say we're talking about a reverse T3 range of like 9 to 30. Okay, let's just throw it out there for the hell of it. And someone's at like a 13 reverse T3 and they think, oh my God, I have a reverse T3 problem. I need to go on T3 only. When the ratio is great and it doesn't really totally call for that. I think sometimes people get a little bit freaked out, you know what I mean? On a number, they're like, well, it should be in the lower part of the range. And you're like, yeah, well, there's a little bit more to that. I think sometimes people will jump to T3 because they heard something about the reverse T3 and sometimes it's not always the case. Yeah. Do you know what I'm saying?
Yep.
What are your thoughts about that, about like reverse T3 levels? Do you still do ratio plus the number?
No, I just go by reverse T3. I like it less than a 12. Free T3, again, like upper quadrant of the range for the most part. And then the how do you feel question and piece all that together. And then it has to be, okay, I'll give you an actual scenario. I have people come in at a 13 a lot. And it's like right at that cutoff, right? So let's say that you're on, again, we're just throwing out numbers. Let's say that you're on 60 milligrams of Armour twice a day. And, you're feeling pretty good. Maybe you want lose a little more weight. Maybe you want a little more energy, maybe just a little bit here, a little bit there. Your free T3 is coming in at like a 3. But your reverse T3 is a 13. In that case, I would not drop your T4 dose. I would not change the dose of Armour. I would leave it alone. I would add in a little bit of T3 and see how you do.
Yeah. Okay. I love that. And these are the nuances, right? Because like I saw something the other day where they were on Armour doing well, going up the ladder. The free T4 was already at like a 1.3 something. And in that range, a little bit above 1.4 would probably be like a suspect, but their T3 really was like still 2.9. And this was, again, a case where, okay, the doctor was like, oh, we'll just give you more Armour. And I was like, you're getting a little close to that T4 level, this is the time to put T3 in and add T3 to the armor, just like you're talking about. And so these are those little nuances that people don't understand. And usually the doctors are more inclined to do the opposite, which is give more T4 or give more of the thing without looking at like, hold on a minute, they're already maybe at the threshold for T4 here. And if this person was given more T4 or another grain of armor, then it probably would drive that reverse T3 up. And now they've given them a reverse T3 problem.
Right. Exactly.
I mean, so yeah, so that's always an option. And look, there are times when adding a little T4 could be helpful too. Neither of us are saying that that's not the case either, but these are these tinkering moments. And a lot of the docs are just willing to give more of the same thing versus doing the actual nuanced tinkering.
Yep. Absolutely. 100%.
Let's talk about, I think you're roughly my age. Let's talk about menopause garbage.
Oh, yeah.
For a second. And we don't need to get into like, the testosterone, estrogen, but just talk about like, what are your thoughts on thyroid? Like either some people need less or more when they go through perimenopause. Can you talk about the effects of this whole change and what that means for thyroid dosing as you've seen it?
Yeah. So it's so fascinating to watch because as we know, going through perimenopause, that's usually when progesterone will tank first. And I see low progesterone and low testosterone in people in their 30s. So it can tank at any point in time. But we'll see normally if someone is not on bioidentical hormone replacement therapy, we will see in the perimenopause population a low progesterone, usually a low testosterone, and then estrogen can be anywhere. You could be estrogen dominant. You could be just your estrogen is totally fine. Or you could start, tanking down and heading into full menopause with lowered estrogen. So the combination is all over the board, but basically for the most part, what I'll see is not necessarily the need for more thyroid medication, but definitely the need for, sometimes I'll get to that, but definitely the need for the bioidentical hormone replacement therapy, because we know that low progesterone is going to produce symptoms of agitation, anxiety, sleep disturbances, water retention, weight gain. So when we bring that in, then all of a sudden it's like, oh, I thought those were thyroid symptoms. They were low progesterone symptoms. And then we have testosterone being low. Testosterone actually protects the body from autoimmune turning on. Now, if you have Hashimoto's, you're going to be like, well, that switch is already flipped to the on position. Thanks. But that low testosterone, right? But then that low testosterone, remember, autoimmune begets autoimmune, where we see one, we see more than one. So with adequate amounts of testosterone, and this is in studies too, this is not me talking out of my ass, adequate amounts of testosterone is actually protective against another autoimmune switch turning on. So you want that adequate amount of testosterone, and not just for that, but to have motivation, to have a sex drive, to be able to build muscle, all of that.
Yeah. And, I noticed in myself, so I take testosterone and progesterone at this point. I still get regular periods, but I take DHEA and pregnenolone every day, which, by the way, that really changed a lot of shit. I had some breakthrough bleeding. That fixed it, to be honest with you. Nice. Literally it's just that. Sometimes it's an over-the-counter thing. And I just was like, okay, I guess this is the time. I need to start to talk to my doctor about this stuff. But what I noticed was this lack in mental motivation and focus. And I knew it wasn't my thyroid.
Yep.
And I said to my doc, look, I kind of want to try testosterone. By the way, here's why he's a great doctor. He's like, great, go ahead and do it. I'm like, don't you want to test me first? He goes, I know this sounds intellectually dissatisfying, but at your age and in general, no, we don't need to test you. Just try it. And like, I love him for that, but like a lot of people come in there and they're like, they want to be tested, and of course, in certain circumstances he does, but in this situation, he's like, no, given your scenario, just give it to you and try it. And literally within 3 fucking days after taking testosterone, my dry eyes went away. I already had a high sex drive, but then it really shot up. And then I really noticed more endurance with weightlifting. I noticed the mental focus came back. This is important. This is what makes the high testosterone in guys is what makes them go fight off to war for us. But we need it too. And so, man, I see so many women suffering through menopause, and it's like, you guys, there are so many wonderful alternatives to this. So like you said, someone in that situation might think they need more thyroid, but it's not that. And then the bloating thing, then the progesterone. So then I was like, okay, from ovulation till the end, I was gaining like 10 pounds. Again, my thyroid dose was fine.
Yep.
It was a perimenopausal thing. The moment I introduced the progesterone, it was like, oh, okay, God, now I don't have to suffer. I barely have PMS. This is great. Holy shit. You know what I mean? And so this time of life requires someone who really understands all of the elements here, because that could be the issue as to why you're still suffering, even though the thyroid labs look good.
Yep. 100%. And with testosterone too, we can tell you that you're probably not going to feel great under a total testosterone of 50. So, I mean, you might feel good at around 40, but you're probably not going to feel good below that whatsoever. You're going to have those. And this is for females.
Give us the range totally there so we understand. Give us the range so we understand what 40
is. Oh, yeah. So testosterone. Oh my gosh, we could do a whole podcast on this. So testosterone range for women pisses me off. I don't even know where it starts. Let's say it starts at a 0. I don't even know where you get cut off. It's some asinine number. Let's say it starts at a 5. So you're actually going to get flagged if you're 3, but you're going to feel like garbage at a 5. So, or a 6 or a 7. It gets cut off on most labs at 45. Now, I just said that the optimal total for women is 50 or above. Now, where that or above lands, that is 100% individualized. I have women at 125, 200 that they're like, don't you dare drop my testosterone lower than that. I am not high. I am great. I feel then I'm like, fine, we're not touching it. I'm not touching it. I'm not going to, but if I was 125, I would have acne like a prepubescent boy. You know what I'm saying? Like it would just be horrible. So,
and this goes to that whole testing thing, which my doctor was saying, he's like, sometimes people have a testosterone that's high in the range and they need it. They need more. And there's nothing wrong with that. It's the same with thyroid. Like that's right for them, where a doctor would go, oh, no, we don't give you testosterone. Your testosterone's already at the top of the range. And that's what you're speaking to. You're saying, no, this is the nuance.
Yes, exactly. And it's all how you end up like aromatizing testosterone. Does it go down the 5-alpha reductase pathway? Does it turn into DHT? I mean, there's so many nuances with that and how you push testosterone and tolerate it. But the optimal level is across the board of where, but I can honestly say that 80 to 90% of perimenopausal, definitely menopausal women need testosterone replacement.
Do you use testosterone cream?
Yes and no. I like injectables better. So my delivery method preference, cream for just individuals that don't feel like doing an injection. Injections for those individuals that are like, hell yeah, get my freaking testosterone up. This sucks. And then if someone is on a pellet, I try to get them off of that unless they say, I love my pellet. But for most women, pellets will spike you really high to like a dude level of testosterone. I've even seen 900 in a woman before, which is an optimal level if you're a guy. And then they plummet down the other side. So there's no steady consistency with pellets. That's why I really like it's pretty still
experimental. Dr. Forsman would say the same thing. He has said that, he tries to stay away from the pellet thing unless he has a patient who's already on it with another doctor and feels great and whatever. But yes, those are the issues with the pellet delivery. It also seems like a very sketchy situation to me. I don't know. I look at that pellet thing and I go, I don't know, Amie.
It doesn't make sense if you're dumping hormones in your system and it slowly dissolves over time to nada. Like that doesn't even make sense for a steady state. Testosterone is not supposed to fluctuate. Like progesterone fluctuate, estrogen fluctuate. That's why we normally do progesterone 2 weeks out of the month or even 3.
And testosterone is every day.
Every day. Yeah. You have testosterone pulses every day. So
what's the level of injection? Like, do you know how many milligrams or what it equals out to in terms of like comparing like your dose of injectable to my dose of taking the cream?
So let me back up with the cream. I will see it in some people. And again, this has to be from the compounding pharmacy, what they're using, what kind of, delivery base they're using, and then the thickness of a person's skin. I will see cream not move a testosterone number at all. And I will see it spike it to 150. It's so individualized. So if somebody's on a cream and they're not moving, we're changing to injectable. But usually with the cream, you're applying it every day. Injectable, I like to do it sub-Q in the fat, because then that actually disperses the testosterone throughout the week a lot more slowly than doing an IM like intramuscular injection. But
is it how do you do the injectables? Is it once a week for you?
I do once a week. And again, a little bit of intuition. If I'm kind of flattening out and not that strong in the gym, and I can actually feel like, hey, maybe that last dose didn't pulsate me up, then I will do another one like in 4 or 5 days, just to hit it again. But yeah, anywhere between 10 milligrams and 20 milligrams a week is usually enough. And then some women, we have to go higher. But if it's in a cream, that's injectable dosing. And it depends on the testosterone. I use testosterone cypionate. With most women, that seems to really do well and keep the androgenic effects low while, giving them the anabolic, the muscle building, the motivation, those kind of effects.
I also noticed some skin tightening. I noticed some slack. I noticed really positive things happening when I took testosterone.
Nice.
Like some anti-aging shit was going on there.
Well, yeah, sure. And it should. Yeah. And it should. Definitely. Yeah. But cream, 5 milligrams a day, if it's being absorbed, I think is good.
Yeah, I think they do. The clicker that I have from the compounding pharmacy, like each click is 1 milligram. And, you start, obviously you start off and you build up, you see what you intuitively figured out. Like I was on one for a while, that seemed good. And then I was like, no. And I went up to 1.5, then I went up to 2, and now I'm at 2 and we'll see, you know what I mean? And again, it's experimentation and figuring out what's right for you, but it's nothing short of a miracle for me. Testosterone. Nice. Absolutely. I freaking love it. I don't know how much more time you have.
I got all the time.
Okay, great. So what else would you like to talk about? Do you want to get into this T2 thing that you have looked into, or is that too confusing for the audience?
No, I don't think it will be. I'll keep it real simple, simple. Because I think it'll be a good adjunct to the T3 discussion too. Mm-hmm. So as we're talking about T3, like you and I just talked about, some people can be sensitive. Some people can go into that hyper state where you really do feel like just jittery and icky and like sticky and sweaty. And it's like you're depressed and anxious at the same time, but you want to bite someone's head off. And it's just that weird, that hyper feeling where, like you said earlier, most people would be like, bring it on. But we're like, no, you don't want to be hyper for too long because you really do feel like ass. So T3 can, as I was talking about, the patient of mine that needs to lower her dose, can push you into that hyper state. And that is the only time that I will say that there is legitimacy in the cardiovascular concern, or if you already have something like tachycardia or you're prone to AFib, obviously we want to, keep an eye on your cardiovascular response to thyroid hormone replacement. So that's what and as you mentioned earlier too, T3 can be catabolic, meaning it does not, when T3 comes in, and you will hear bodybuilders talk about this too, when T3 comes in, it does not differentiate between burning fat and burning muscle. It will burn both. Now, when you're hypo, who cares? Because you just want to get out of that hypo state, right? If you lose a little bit of muscle, who the fuck cares? Just burn my body fat and make me feel better, right? But the cool thing about T2, when you really start looking into, and the chemical name for it is 3,5-diodo-L-thyrionine. That is T2. Now we can find T2 is produced by your thyroid. T1, T2, both produced by your thyroid. We find T2 in NDT medication, but at a very, very low dose. When you start looking at the studies of an increased dose, and I mean in a 60 milligram tablet of Armour, there is roughly, and this is just really roughly 8 to 9 micrograms of T2. Then when you start looking at the studies, they're using 150 to 300 micrograms of T2. But what's interesting is that T2 only targets fat. It leaves muscle alone. And when we study the muscle effects of T2, and this is, anyone who talks about this says the same thing that I'm going to say too. This is not meant to replace exercise, but we find that it has an exercise effect. It's like exercise in a bottle kind of thing, where you actually get some stimulation of the muscle, as well as increase resting metabolic rate, your basal metabolic rate, your BMR increases with the addition of T2. That's what we're finding in the studies. So one human study, and this is an area that really needs more research, but of course we know that the stuff that really works isn't going to get the love that things that can be turned into a drug by a drug company. That's another rabbit hole. But when we look at the true human trials of T2, 3,5-diotyl-L-threonine, we do see that those subjects lost body fat percent. They lost 4% body fat percent in 28 days, which that's huge. I mean, 4% doesn't sound big, but when we're talking about body fat percent in a short amount of time, that's big. Yeah. So they lost that. There was no thyromimetic effects of it, meaning your thyroid numbers didn't change. T2 doesn't increase reverse T3. T2 does not increase your free T3. So you're not going to appear hyper on your labs or anything like that. And there's no cardiovascular effects of T2. T2 goes right to the mitochondria. So that's the difference, is that it's working at the mitochondrial level. So you do get increased ATP production. You're going to feel more energy from it. You're going to get the increased basal metabolic rate, but it's not working on the thyroid. It's working at the mitochondrial level. So you're not getting the thyromimetic effects from it. I think it's an up and coming thyroid hormone right now, because people ask me this all the time. Well, can my doctor prescribe T2? No, it's in supplemental form. I've been using it with my patients for years now. I mean, like over a decade, but it's not in prescription form. It's only in supplemental form. But I do think that this is going to be kind of the next wave, like T2 for obesity, these new anti-obesity, like insulin resistant, like Mounjaro, which are really peptides. Like I think peptides and T2, I think this is going to be that next wave of safe ways to address the obesity epidemic that we're seeing in our country without, using the crazy stuff that, gives people
metformin and,
like the fat burners and the phentermines and all this. So I just find it really, really fascinating when you start diving into the research on it.
And is that, and then that you're saying for people who are not on or on thyroid hormones either way, or particularly for people that are on thyroid hormones still struggling with weight stuff or insulin resistance?
Yeah, that's a great question. Good question. So those who are on T4 only, I would say you probably need this, because there's a lot of your listeners are probably just stuck on T4 only. It's probably not working that well. Then I would add in T2, because you're going to, at least if you're stuck in that T4 only, I can't lose weight, this is bullshit kind of state, then if you add that in, you might actually get that increased basal metabolic rate, the fat burning, and the increased energy with it. Then if you're on something like an NDT, T4, T3, like we said, NDT only contains a teeny tiny amount. So you'd be safe adding that in. T3 only, again, it's not going to increase your reverse T3. So I've taken it. It does not push me hypo like T4 does. And how I tend to use it, because my metabolism is pretty good, I will use it when, let's say I'm, I just got back from vacation or went off the rails over a weekend with parties or whatever, and just ate too much and put on something. Then I'll take it for like a week, shed the weight, increase my metabolic rate, and then bring it back down. I'm thinking of experimenting with it to reduce my T3 dose as well, because like you said, T3 does eat your muscle. It is catabolic to a certain level. And the amount of T3 that I'm on, I do want to put on more muscle tissue. Now the testosterone's helping. Obviously I lift heavy, but I want to be able to back off on my T3 a little bit. So that's a whole other experimentation that I plan on doing after I test my T3 on the dose that I'm on. I want to do, like I said earlier, that 2-hour test to see where my free T3 comes in. But then I want to start experimenting with it to reduce the T3 dose that I'm on too.
Okay. So just devil's advocate here. Someone would be like, well, wait a minute. If that dose is right for you, why would you want to reduce it? Just to see if you can be more T3 efficient, just because it's cheaper and easier anyway to take less. Like if you're functioning well in it, then why would you want to take less?
So, well, basically because of that catabolic effect, as we age, I mean, I definitely notice a decrease in the ability to put on muscle. Right. I mean, I would.
Yeah, that's an age thing for sure. I mean, that one thing we can chunk up to age.
Oh my gosh. I mean, I used to be able to like breathe and my thighs would grow. And now it's like, I'm seeing that decrease, and just in my arms and whatnot. I'm just that muscle look, that athletic look is starting to dwindle down. So, I mean, I know I lift heavy. I know my workouts are good. I know my protein intake is good. So the only really other factor is the T3, because I'm on testosterone. So, yeah, I just want to play around with it for that aspect. And then also, when we experiment, we can help other people better. So in doing so, maybe that will help someone who is like, oh, I just can't go up in my T3 dose. I don't feel well. I go hyper. This is not right for me. Or those people that are really super sensitive to T3. And maybe this is something they can add in to still get the effect without the effect. So yeah, this is why we do things on ourselves, just so we can figure it out.
Experiment. I am like a fucking human experiment, basically at this point. But you know what? Thank God we did, because in the tinkering, you find the answers and you're persevering through, again, not settling for anything less than feeling awesome.
Yep, exactly. And even those N=1 experiments, I mean, it really makes you step back and go, oh yeah, well, maybe this is happening to other people too. So I think the N=1 is fantastic because it gives you information that maybe you're not going to find in a published study, which are skewed anyways.
Let's just last convo before we wrap up is based on the heels of what you just mentioned, which is because you and I are both the same age in perimenopause, menopause times, doing these, bioidentical hormone replacement situations. 100% I used to be able to blink, like lift weights once a week and things were good. Arms were nope. Guy, you get to a certain age, you can't fucking get out of lifting weights. You can't, not only just for the organ reserve, it's just nothing works. Nothing works. Other than like, you don't have a choice at a certain point. Like you have to lift the weights, not only again for the bone density and all the other stuff we know that's good about it, but literally because of this aging sort of muscle wasting, it's even more important in your 40s and above to like do 45 minutes a day if you can, or something, but and fuck off with the cardio, like just bare minimum on that and get to the weights. I've noticed that myself. The only times I actually make any progress with body shape and body composition is when I'm lifting weights. And I wish I didn't have to. I'd love to hike every day and have that be it. I'd love to lift weights once a week and have that be it, but I'm not 25 anymore,
No, not at all. I stopped doing cardio. Oh gosh, probably about 3-4 years ago. And thank God. I mean, that's so liberating to not have to be a hamster on the treadmill, but and then I preach the message to my listeners, my audience as well. Stop being a cardio queen. Just go lift heavy shit and stop being a cardio queen. Because if you're lifting heavy, your heart rate is going to go up anyways. And if you want to throw in a couple burpees or whatever to get your heart rate up and feel like you're doing some kind of cardio, go ahead. If you want to warm up because you're addicted to the Stairmaster and you want to do 5-10 minutes of a warm up, go ahead. But beyond that, I think the Peloton is the worst thing that's ever been invented for women, because they're sitting their ass on that damn bike and they're doing cardio over and over and over again. No weight bearing whatsoever. They're losing muscle mass like crazy. And they think the Peloton is going to be their answer. Like,
and they're just actually driving themselves towards being a sugar burner anyway when you're doing these glycolytic exercises. So now they're going to need the carbs, and then they have to they burn the carbs and they release the carbs. They're not doing really like a super fat burning type of thing.
No. Yeah, no, just lift heavy and your heart rate will go up. You will burn fat, but you're going to be building that sexy lean muscle that is more metabolically active anyways. And then yes, for longevity, sarcopenia is real. I mean, if you show me a 70-year-old with muscle, number one, they're lifting, they're taking bioidentical hormone replacement therapy. If you show me a 70-year-old who doesn't lift and isn't taking hormones, they are frail. Yes. They are frail and they're skinny, or they're skinny fat.
Yeah. And, I mean, my mother for years my mother has a great diet, she eats broccoli every night, whatever. She's very healthy, but she always took the calcium and the magnesium and did all the stuff. And, then she got osteoporosis. And I was like, here's the perfect example of how you cannot get away with just taking a walk every day.
Yep.
At a certain point, calcium doesn't do garbage for you. You actually have to challenge the muscles that are attached to the bones in order to give yourself a chance, right? So it's not just osteoporosis. This is, again, physique, weight loss, fat burning, lifting weights is the way to go. I've noticed it in myself. And again, you just see it over time. You start to hit your 40s and you're like, wait a minute. Let's tell us, first of all, you have a podcast, the Thyroid Fixer, right? Is that what it's the title? Yep. And then tell us, we'll put everything in the notes to connect with you, but tell us, are you most active on Instagram? What's your website? I know you obviously still take clients, which is wonderful. So give us the rundown on how we can work with you and where we can find you.
Yeah, absolutely. So my website is dramieHornaman.com. And on there, you can book a free discovery call if you're interested in figuring out, your health and finding out how to work together. I have a prescriber on my team that we prescribe to multiple different states. So we have that list up on Facebook too. Most people, I'm most active on Facebook because I do have a private, it's a public Facebook group, but private Facebook group that you can join. And that is called Dr. Amie, the Thyroid Fixer, Love Your Mirror, because I want you all to love your mirror. So we're chatting in there. I mean, that's at least a space where you can post your labs and ask questions, and it's a very warm family community where you will get support from other members in there as well. And, I'm just there to support and give just free advice and guidance. So you can jump in there as well. If you don't know me, you can get to know me in there, listen to the podcast, and then we can take it from there.
I love it. I am so glad you're out there because, again, just having someone else who's out there who's an expert, but who's also on T3 only and understands all of these nuances between the different stuff. There are not a lot of those people. Mm-hmm. And so I'm just so grateful for your work, to know about you and have these conversations with you. And again, just another great resource for someone who can help you guys fix your thyroid problem. By the way, on that, I'm closing. It's fixable. Don't let anyone ever tell you that this is not fixable, right? Yeah. Now, look, it might take long. Like if someone's got, menopause, Lyme disease, EBV, okay, it might take a little longer. But you know what? When someone discovers this, short of like a crazy situation, you can really start to feel great within 3 months. Maybe it would take a year if you had all of these compounded issues, but this shit is totally fixable. So please, when I hear people be like, I'm sure you get it too, they're like, I don't know. I've been suffering for 10 years. I might be a hard case to crack. You're like, no, you're not. You just have a dumb doctor and you don't know enough. That's really that's the only thing.
Oh, I'm so happy you said that because I do hear that all the time. Everyone thinks that they are a tough case. Everyone. And 9 times out of 10, like you said, Elle, it's short of it being this very complex. There are multi different layers that we have to address. Most of the time, you're just like the next person. And I don't mean that in a degrading way. I just mean you're easy. You're easier than you think because you are in you and you are suffering. And you're like, oh my God, this is so horrible. Nobody else can feel this way. This is the worst that anybody could ever possibly feel. And there's no way anyone's going to figure this out because my doctor already told me that I'm normal. So what the hell is going on? No. Like Elle said, you just have a dumb doctor, like you just uneducated, not a thyroid specialist, whatever. And you just need the basic answers. And once you have those, you're going to be amazed at how quickly you turn around.
Yeah, it can be and I'm sure you've had it too, where people are like, can this make you happy? You're like, yeah, it completely does make you happy. We have more of these receptors in our brain than anywhere else. This is an important hormone. So
the Band-Aid antidepressant your doctor gave you won't, but
that's right.
That'll work. Thyroid actually might.
Yeah, that'll work for like a month, and that's not going to work because they never got to the root of it. So, so grateful for your work. Wow, we could have like a 5-hour discussion because it's so much fun to talk to someone who actually
so fun.
In this. Thank you so much, and everyone, check out Amie, check out her podcast, and again, another really great resource for helping you get beyond this. And it's totally fixable. Do not give up. Persevere. We did it. We see it all the time with clients and patients we work with. So you are no different. It doesn't matter if you've gone through 500 doctors. They were just dum-dums. That's all.
Yep, exactly.
All right. Well, thank you so much.
Thanks, Elle.
Hey, listeners. Over the years, a ton of companies have approached me to collaborate, but I will only promote companies whose products I believe in and that I actually use and consume on a regular basis. So let me tell you about some of my favorite companies that I can offer you discounts for. Rep Provisions, an amazing company doing incredible things for our planet, topsoil, and animals with regenerative agriculture, and it's my #1 source for quality pasture-raised meat and chicken. Visit repprovisions.com and use code L15 for 15% off. I'm also obsessed with a company called Carnivore Crisps. They make a lean, all-natural, and delicious alternative to conventional snacking, made with just real meat and real salt. Totally addictive, and my favorite ones are the beef brisket and the ribeye. Visit carnivorecrisps.com and use code PALEO10 for 10% off. I also love and regularly use Paleo Valley products. They make amazing supplements and delicious paleo products. I use the superfood greens powder, grass-fed beef sticks, the organ complex, and their bone broth bars. I love the lemon and apple. I also use their essential C complex and more. Visit paleovalley.com/promos/Elle Russ for 15% off. I also love Primal Kitchen. They make delicious paleo-approved, gluten-free, grain-free, soy-free, and no refined sugar products, and I use them daily, from their collagen powders and sauces and marinades to their avocado and olive oil. So good, so healthy. Visit primalkitchen.com and use code L10 for 10% off. I also love paleo powder and use it almost on everything I cook. They make incredible seasoning blends, and they also have these incredible grain-free coatings that feel just like crispy breadings that you would have had prior to knowing that there's another way. So visit paleopowder.com and use code L15 for 15% off.